This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. Hey NPs, were you unable to attend the NCNP Fall Virtual Event livestream? If so, we've got you covered with NCNP On Demand. You can view all of the recorded livestream sessions until January 18th, 2024, and earn 55 CE credits and 30.5 advanced pharmacology hours at your own leisure with NCNP On Demand. Register today. In this episode of the Nurse Practitioner Podcast, Dr. James Jackson discusses long COVID. Welcome, Dr. Jackson.
It's really great to be here with you. Thank you for having me on.
Now, first, how did you begin working with long COVID patients?
It's a long story, and I know we've got a lot of questions to cover, so I'll try not to make this question take the entirety of the episode. The long and short is that since about 2000, I had been working with survivors of critical illness, people who were hugely sick in the ICU. And when the pandemic started, of course, I was working with COVID patients in the ICU, surviving the ICU. And as we were engaging these patients, COVID survivors from the ICU, what started happening was people started approaching us who said, I was never in the ICU, but I was in the hospital. I've got some difficulties related to COVID too. Can you see me? And the answer, of course, was yes. It's our privilege to see you. And as we started seeing hospitalized patients with COVID, then we were approached by people with COVID who were never hospitalized, who said, I had just a touch of COVID, but I'm having persistent problems now that I didn't have before. I have long COVID. Can you see me? And the work just evolved from critically ill survivors with long COVID to hospitalized patients who had long COVID to people who were in the community, really around the world, who had long COVID. And before you knew it, we were seeing throngs of people, largely in a support group that I'll discuss later. But it was a lot like the Field of Dreams. If you build it, they will come. We had a program, we had an infrastructure, and people heard about it. They just started coming and coming and coming. And we've learned a lot in this long season of treating these patients. And it's quite a blessing to work with them.
Thanks for sharing some of your background. How do you define long COVID?
People grapple a lot with this definition, long COVID. And as with many things, there are textbooks and there is real life, and sometimes those aren't exactly the same. In general, long COVID reflects a phenomenon where you had COVID, you were acutely ill with COVID, and those acute symptoms, they go away, and you're left with persistent residual symptoms a month later, 2 months later, 3 months later, 6 months later. You have new problems you didn't have before. And if you had problems before, those are worse than they were before, and those aren't going away necessarily. That's what we call long COVID.
Thanks for the explanation. How common is long COVID? Is it a single clinical entity or is it many different things?
When we talk about long COVID, it's really complicated because many people talk about it as if it is a single thing. And the problem is, I think most of us, including many nurse practitioners, I'm sure, who are listening to this program, most of us have observed that long COVID patients are not a one-size-fits-all. There's a lot of individual variation. Sometimes they have cognitive problems as a primary issue. Sometimes they have physical problems, including fatigue or cardiac problems as a primary concern. Sometimes they have mental health issues as a primary concern. Sometimes they have all three. So I think if we're going to be thoughtful about treating people with long COVID, one of the things we have to recognize is that it has a lot of different clinical expressions. Some of them obvious, some of them very nuanced, but it's far more than one thing. And it's also hugely common. People debate a bit about prevalence. I've seen numbers, I've reported on numbers, talked about numbers as high as 200 million people around the world with long COVID. Some would say that number is high. But even if we cut that in half, even if it were 100 million, that's 2 or 3 times the number of people who live in California. That's 5 times the number of people that live in New York City. That's 100 times more than the number of people that live in my hometown, Nashville, Tennessee. So giant numbers of people every day struggle with long COVID. And that's why I think it is really the public health issue, I would say the forgotten public health issue of the day.
Those are some interesting points. Now, what kinds of mental health symptoms do long COVID patients have?
They have a wide range of symptoms, and some of those symptoms are likely driven by the disease itself, perhaps due to the effects of things like neuroinflammation. And often those mental health symptoms are driven by the circumstances that long COVID causes. So, for instance, if you had a great job, you're a partner at a law firm, you're billing a lot of hours, and now you have cognitive problems, now you're functionally disabled, can't go to work, you get easily fatigued, you're not meeting your standard, you're having a hard time getting out of bed, you're at risk of losing your job and your entire career. It's quite normal in such a situation to get depressed. It's quite normal to get very anxious. It would be abnormal not to be that way. When you're critically ill in the ICU with COVID, fighting for your life, it's quite normal to develop PTSD. So many of these mental health symptoms are a normal, are a typical, even expected response to stressors, and I think it's important to highlight that. In general, these issues occur in the following areas. They occur in the domain of anxiety. People often have debilitating anxiety. They have significant problems with depression. They have often really significant new or worsening OCD. And PTSD is a problem for many of them as well. PTSD flies under the radar a bit because far too often we associate PTSD with things like combat or sexual abuse. PTSD results from those things, but PTSD is much more than that. PTSD can result from medical trauma as well. So all of those mental health problems and some more to boot, I think, affect long COVID patients.
That's some eye-opening information. What kinds of cognitive symptoms do these patients have?
There's a term that you've heard, people have heard it bandied about ad nauseum, I think, and that term is brain fog. People talk about long COVID and brain fog. And certainly long COVID patients, they'll report feeling foggy, but many of them don't really like that term very much because they feel like it minimizes somewhat the intensity and the severity of the problem at hand. And I agree with that. I actually think that it does. And I think the truth is often when people have cognitive problems in long COVID, they're better explained by a brain injury than by brain fog. And what happens functionally is that people struggle with areas including attention, that is, they're very inattentive. They have problems with executive functioning, meaning they're pretty disorganized. They have problems with memory, although typically they don't have dementia. It's not amnestic memory deficits that they have. And often they have really pronounced problems with processing speed. Processing speed, I think, is the signature cognitive injury in the context of long COVID. That is, people's brains, the wheels of their brains, if you want to think of it that way, just turn really slowly. And people have a hard time coming up with the words they want to use in a sentence. They have a hard time responding rapidly. They have a hard time interpreting social cues. All of those problems together create a scenario where people have really substantial problems in functioning.
We appreciate you sharing that information. What do you think of the term brain fog, or is a brain injury a more accurate term?
The term brain injury, I think, in many ways is a better term. For one, it's a more accurate term. For two, and this is crucial, when you think of brain injury, you think of rehabilitation. That is the the medical community is aware that there's a pathway to recovery in the context of a brain injury. And that pathway to recovery typically involves rehabilitation of some sort or other, cognitive rehabilitation. So when we send our patients to get rehabilitation, often done by speech and language pathologists, typically involving teaching patients compensatory strategies and things of that sort, when that happens, our patients get better. Their cognition gets better. Their functioning improves. They really get better. And it's a hopeful message, I think, that rehabilitation can improve cognition. But that rehabilitation gateway, that pathway, generally only opens when healthcare providers are reminded, when they remember that this is a brain injury. When it's brain fog, often that's brushed aside. It's looked at in a minimizing kind of a fashion. Nothing is done. So a brain injury, I think, is the ticket to getting rehabilitation, which, if done correctly, can be a game changer for our patients.
Thanks for that clarification. Can cognitive problems with long COVID be rehabilitated?
It's a great question. We've talked a bit about the idea that cognitive problems in long COVID are often brain injuries, and we know from literally decades and decades and decades of research and clinical practice that people with brain injuries, whether they are traumatic brain injuries, TBIs, or whether they're acquired brain injuries, ABIs, they can improve both due to the effects of neuroplasticity and, crucially, due to the effects of rehabilitation, they can improve. And there is another way, I think, in which they can improve that isn't talked about very much, and that is that sometimes these cognitive problems are not due to a brain injury. Sometimes they're due to the cumulative effects of things like anxiety and depression, PTSD, all conditions that are well known to have adverse effects on people's cognition. So if your cognitive problems, if your inattention is due to the effects of depression, if it's due to the effects of anxiety, one way to improve that cognition is to treat the depression. One way to improve that cognition is to treat the anxiety. So that's another piece, and I think it's really important for the NPs listening to realize that there are two routes to enhancing cognitive recovery, and one of those is, yes, we're going to send you to cognitive rehab. The other is, if appropriate, we're going to improve the cognitive functioning that a patient has by addressing unaddressed mental health issues. And when those are addressed, people get cognitively sharper, they get crisper, they get more functional.
Well, it's good to hear that patients can be rehabilitated. What should NPs know about long COVID patients?
I think they should know, as I mentioned, that this is not a one-size-fits-all situation. I think they should know that in the cognitive realm, many people look quite normal who are not. I think that's really important because there are many patients, so many that I have seen, who look sharp, who look well put together, who look like they're performing fine on a cognitive assessment. Even if you give them a cognitive assessment, they're doing fine. And if you drill down and lean in, you'll find out that they feel like they're quite far off their game. So asking about cognition in long COVID is crucially important. Not assuming that everything is fine just because it looks fine is crucially important. In the mental health realm, I think it's really important for NPs to recognize that many patients with mental health concerns are reluctant to endorse those in the context of a clinical encounter, whether it's with an NP, whether it's with a physician, whoever it's with. They're very reluctant to endorse those, partly because it's hard to talk about mental health issues, for one, partly for two, because they're very worried that they are going to be stigmatized. We've had many patients who have said that they reported depression or anxiety to a medical provider, and that medical provider kind of weaponized that against them, basically said, now that you've admitted it, this is proof that it's all in your head, right? Now that you've admitted this, that explains all of your medical problems. And then these patients often, they mightily regret, they powerfully regret endorsing those mental health problems. So if NPs can create a climate where it can feel safe to disclose your mental health challenges. That will be a lovely development, and that will be really good progress.
This is some great information for our listeners. Thank you for sharing.
You're welcome. And if I can add one more thing, the other thing I would highlight here for NPs is that I think they need to recognize that long COVID is very much a family problem. We see this time and time and time and time again. In the West, we often identify medical problems as residing solely in an individual, right? You have long COVID. But the reality is that when people have long COVID, that long COVID impacts a lot of domains of functioning. It impacts family systems. It impacts the mental health of children, right? It impacts things so completely. I think it's not only the case that the patient in front of you is the patient. It is the case that that entire family that patient is engaged in is likely suffering. So if there's a way to cast a wide net in the context of treating individual patients and recognize that outcomes will be better if familial issues will be addressed, broadly speaking, I think that's what MPs should do.
Do you see long COVID patients improve?
I see long COVID patients improve every day in almost every way, which is to say physically, we certainly see people get better. We see people get much better cognitively. We see people get better from a mental health standpoint. This is not to say, and I don't want to say, that everybody gets better. It's not remotely the case that everybody gets better. We're in 2023 now, late 2023, by the time this airs, and many people will have had long COVID for literally 3 years. There are people who will be struggling. They've been struggling for 3 years. But with that acknowledgement, there are also many people who are a lot better for two reasons. One, they're a lot better because their symptoms have diminished. Two, many of them are a lot better because even though their symptoms perhaps have not diminished, they have found a way to accept, they have found a way to learn to live with difficult things. And I think the second point is so crucial. That is that too often, the way this is framed is, and this isn't only true of long COVID, too often the way this is framed is, if I can only find a way to get rid of all of my symptoms, then I'll be okay. Then and only then I'll be okay. And that sets up what I think is a losing proposition, right? Because what if your symptoms don't go away? So part of improving is learning to recognize, and typically this is done best in a therapeutic relationship with an MP or a mental health provider, someone who's a professional who's caring. That is learning, I can find a way to be okay even if my symptoms don't get better, right? I can find a way to live with some hard things that I don't want. That's a long journey to get to that place, but people get to that place. And when they get to that place, it's a lovely thing. It's a sight to behold. And we see people improving that way also.
Well, that's good news for everyone.
Absolutely.
Tell us about your support groups for long COVID.
You know, in a world of really good developments related to long COVID, that is for me being engaged in a lot of meaningful things. Perhaps the most meaningful has been the development of a support group program, peer support group program for long COVID survivors. And that support group program takes the form of multiple support groups. On any given week, we typically have 4, sometimes we have 5, sometimes we have as many as 100 patients from around the world participating via Zoom in these support groups. And they're a lot like 12-step recovery groups. If people have been a part of those, people are talking about issues of shame. They're talking about issues of identity. They're talking about how to reclaim key aspects of their life that they feel like have been lost. They're talking about issues of acceptance. They're talking about learning to lean into hard things, and they're supporting each other in the process. And they're engaged in a lot of really lovely modeling. That is People are being vulnerable, and new group members are seeing what it's like to be vulnerable. People are learning to be advocates for themselves. Other people are watching that, and they're following suit. So there's a social modeling component, to be sure. But what we know since the start of the pandemic is that isolation is a huge problem, right? It's a gigantic problem, especially with people with long COVID who are worried about getting COVID again. Often they don't know other people like them. So putting people in a real live community, albeit virtual, of other survivors whose stories are a lot like theirs, it's incredibly empowering, and people are nurtured, challenged, healed, and recovering in the process.
It's great to hear these types of groups are available to those suffering from long COVID. Finally, you wrote a book about long COVID. What was the genesis of that, and could it be helpful for medical providers?
I did write a book, and I'm learning I'm not very good at self-promotion, but I think it could be quite helpful actually to the nurse practitioners listening. Back in 2018, I'll just tell my own story a bit if you'll indulge me. Quite out of the blue, during a stressful season in my life, I developed obsessive compulsive disorder. And it was really hard. I didn't know what was going on. I knew that I didn't want it. I knew I wanted to get rid of it. And I went to see a psychologist. She's amazing. Jenny is her name. And she said, after diagnosing me with OCD, she said, Jim, let's find a way for you to live with this. And I said, not so fast. I don't want to live with this. Let's find a way to get rid of it. And she said, this is a chronic illness. I'm not so sure that you're going to get rid of it. And that was not the message that I really wanted to hear. And that began really a 2-year journey of acceptance, of learning to live with a hard thing that I didn't want. And when the pandemic came, I was well into that mental health journey of learning to live with things that I didn't want. And it occurred to me that there were insights from my own story that in many ways were quite relevant to the lives of people with long COVID. They didn't necessarily have OCD, but like me, they had rapidly developed something that turned their life upside down that they didn't want. Like me, they were desperate to get rid of it, and there was perhaps no getting rid of it. So that insight, I've lived with really hard, unwanted things, and I found a way to thrive over time with the right support, and maybe you can too. That was one of the key reasons for the writing of the book. That and engaging in these support groups and realizing just how much help people needed. So what the book is about, it's called Clearing the Fog: From Surviving to Thriving with a Long COVID Practical Guide. What the book is about is finding a way, really finding a pathway to navigate this chronic illness, learning to advocate, learning what kind of specialists should be on your medical team, learning what empirically validated treatment you should pursue, learning how to find a way to accept these unwanted things and grow in the process. Initially, my thought was that the people who would benefit the most from the book were patients, and I think that's true. But time and time and time again, I'm hearing from medical providers who are saying, oh gosh, this is hugely helpful for me. This is teaching me what it is like to be a long COVID patient, right? I've got a window into the world of long COVID that I didn't have before, Dr. Jackson. And I think it's really exciting to me that this could be a bit of a manual for NPs and physicians and nurses as well. And it's proving to be that way.
Thanks for sharing that personal story, Dr. Jackson. And to our listeners, we hope you check out Dr. Jackson's book, available on Amazon. The link will be in the episode description. Thanks so much for your time today, Dr. Jackson.
Really my pleasure.
For more great content from the nurse practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner podcast are not clinicians. However, we created the Nurse Practitioner podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.